Hello, everyone, and welcome to the 2020 Rural Health Clinic Workshop presented by the Oregon Office of Rural Health. My name is Rhonda Ann Gerst, and I am the Rural Health Clinic Program Manager and will be the moderator of this session today. First, I'd like to thank our partners, Gold Partners, All Care Health, and Oregon Rural Health Association. Silver Partners, Eastern Oregon Coordinated Care Organization, Oregon Association of Hospitals and Health Systems, and Riverhouse on the Deschutes. Bronze Partner, RQI, and our Copper Partners, Westcom, American College of Education, and InquiSeq. Their continued support during these difficult times has made it possible for the Office of Rural Health to offer the conference and workshop to you at no cost. Next slide. Session evaluation. After this session, you will receive a survey. Please help us continue to make improvements by completing the survey. In addition, this is how you will receive CE credits, and you will be entered in a drawing to win a $100 gift card. Next slide. To present RHC Telehealth and Care Management Service Billing Update, please welcome Charles James Jr., President and CEO of North American Healthcare Management Services. Welcome, Charles.
Thank you very much for having me here today to speak on telehealth care management. We've got some commingling that we're also going to include. So thank you, Rhonda Ann. Thank you, the Oregon Office of Rural Health, for inviting us to speak on this topic. And of course, thank you to all the partners that Rhonda Ann just mentioned. I've got some exciting announcements about some of those partners, so stay tuned. So today we're going to talk about telehealth. There we go. That's me, as you can already see on the video, President and CEO of North American Healthcare Management Services. I'm also I'm serving a 2-year term as the president of the National Association of Rural Health Clinic. So I'm really plugged into all of the issues that are affecting rural health clinics, and especially what the current and future of telehealth is. So let's dig into what the current status is. We're going to look at the current RHC, FQHC telehealth billing requirements. We're going to talk about some of the federal changes that have and have not taken place yet relative to our ability to offer telehealth in the rural health clinics. And we're going to look at what Oregon has done to broaden access to telehealth services for providers and patients in the state of Oregon. And we're going to talk about commingling. It's a seemingly, it's not exactly a complementary topic to telehealth, but it's a really important topic that all of our RHCs confront, and we continue to try to navigate what commingling means for us in rural health clinics. First, it's always important to have some definitions. And as we go through this presentation, we're going to set the groundwork for the language that we're going to use to describe these services. In policy terms, of course, we can get really down to the micro level of some of these different terms. So it's important that we're all on the same page as the policymakers. When we use the term telehealth, we're really referring to the broad range of services that we can provide in a healthcare environment using audiovisual technology. Telemedicine really refers to the professional services that we can offer and render via telehealth platforms. So just as a distinction, telehealth versus telemedicine, and we're largely talking about both today, and we'll see why. It's very important to understand in the context of RHC and FQHCs how we were different from the rest of the world as the COVID public health emergency settled in, as the curtain started to close last spring, what we were able to do and what we were not able to do, particularly at the federal level. So there's been very large disconnect in most states between what the states already had defined in their service definitions versus what the feds allowed us to do or what not to do. And of course, there are 51 different ways to do that at the state level, right? 50, however you count them. So it's important to remember for Medicare, we have this issue of originating site versus distant site. When telehealth was established, when the law was passed in Congress establishing telehealth, so our statutory telehealth definitions, when we talk about things being statutory in nature, we're talking about the law that creates these policy issues. RHCs and FQHCs were statutorily defined as originating sites, which is where the patient is, and we were prevented from acting as distant site services for the purpose of our RHC, which is where the provider is. So the intent was, of course, the patient comes to a defined originating site. The originating sites were defined in the statute as critical access hospitals, rural health clinics, federally qualified health centers, and a couple other locations. The patient had to be seen via telehealth at an originating site. The home was statutorily excluded from being an originating site. So pre-COVID, the only telehealth service we got in an RHC was, and it's important to say that the RHC could bill, not necessarily the providers involved, but the only service we could get for the RHC or FQHC were the originating site charges, and that's our 7080 Q3014, and that's the HCPCS code, excuse me. And we were only eligible to be paid $23.17 for an originating site service. So we would sit the patient at the RHC and FQHC, and a remote provider in the big city, right, where the specialties are, specialists are, would see the patient via audiovisual technology. They would bill the remote site. They would bill a fee-for-service E&M largely, is what they would do. We would bill the originating site. We could never be the distant site, and the remote provider could never be paid an RHC encounter. So that was pre-PHE and the way things were set up statutorily. So pre-COVID, originating site had to be the location where the Medicare beneficiary received services. They had to be outside of a metropolitan statistical area, which means outside of an urban or suburban area. It had to be in a HPSA. We know well what those are. So pre-PHE, these were the approved originating sites. So those are the originating sites. If there were a physician or nurse practitioner office, it had to be in a rural area. Our rural health clinics, FQHCs, were statutorily approved sites. Distant site providers were statutorily defined as these. You see, RHCs and FQHCs are not on here. So pre-COVID, we could not be as RHCs, FQHCs, distant sites. Enter COVID. We just had actually this slide's out of date, pardon me. The current PHE was just renewed. It was just renewed on 10/23. So it expires on 1/23/2021. So each public health extension lasts 90 days. The current public health emergency was initially announced in March. It was effective of January 28, which was the WHO announcement. And it's been extended 90 days, 90 days, 90 days. And all of the telehealth provision gains that we've had during the COVID crisis have been because of this public health emergency declaration. So the public health emergency declaration, we could have whole other presentations on the effects and the waivers and who's waived and what's waived. We're not going to do that today, but just know we have a blanket 1135 waivers during the public health emergency, which have allowed us an enormous amount of flexibility both in where we can provide rural health clinic services. We can go across the parking lot if we need to. We can go across the street. We can go down the street. We've got a lot of flexibility. And these are blanket waivers, and this also affected our telehealth services. So as we know, part of the problem with telehealth at the outset were the platforms that we were able to use for telehealth services were really out of sync with what the patients had available. So our patients needed to communicate, and we're talking Oregon, very limited internet and cell phone reception. I'm sitting in Illinois. I still consider myself a Missourian. In Missouri, we did a study. One of our clients, FQHC clients, did a study. 50% of the students in their rural county, which is actually, you wouldn't think of it, but in Missouri, is not dissimilar from what we get in a lot of spots in Oregon. These are some very isolated communities. We call it hill country. It's not out in the mountains. But, it's pretty rough rural territory back there. Kind of think Appalachia, Ozarks. But 50% had internet and cell phone. So all of the platforms that we needed were not available all of a sudden to our patients during this COVID health emergency because we couldn't get a BAA on a lot of these. So the Office of Civil Rights, first of all, came in and waived the restrictions and are not going to audit people or pursue any actions against use of Skype, UpDoc, Zoom, most importantly, FaceTime, which is an Apple product, not to be confused with Facebook. FaceTime we can use. There are not going to be OCR actions against FaceTime, but do not use Facebook Live or TikTok. Those are both public-facing platforms. So that means if you're doing a telehealth visit on Facebook Live, you are streaming that to the public. So FaceTime good, Facebook Live bad. TikTok, if you don't know what it is, you've probably heard of it just in the news. It's a youngster application. It's for those whippersnappers. But no, really, TikTok and Facebook Live, neither are valid, even during the public health emergency, valid for valid for telehealth services. So 1135 waivers also included our ability for a wider range of providers and all of our existing rural health clinic providers to practice via telehealth. And that includes our rural health clinic as a distant site, but most importantly, it includes the list of physician fee schedule services that are approved for the rest of the non-rural health clinic, non-FQHC world that are paid on the physician fee schedule. So this was the outset of our problem, is that all of the waivers as they started to get announced back in the spring affected payments on the physician fee schedule. And all of a sudden, everybody started saying, oh, well, wait a second, we're going to do all these waivers, but they don't affect rural health clinics, so we had to get some special exemptions. Regardless, the list of services that we're talking about are, and that there's a link on this slide right here, CMS website, we've got the list of services that are payable under the Medicare physician fee schedule when furnished via telehealth. So those are our services that we can provide via telehealth in our telehealth 1135 waivers. It also allowed beneficiaries to get telehealth services in any facility, including our physician office, hospital, nursing home, or rural health clinic, as well as from their homes. So the patient could be in their home. Remember, pre-COVID, the patient could not be in their home as an originating site. Patient's home can be an originating site. Rural health clinic, FQHC, can be a distant site. So that was really important 1135 waiver number one for us. We went through a host of kind of incremental policy interpretations. Remember, I just said we had all of these waivers that started to roll out, but we discovered that there was an exemption. We had to get special permission for rural health clinics to function as distant sites. So we got that. And if anybody cares, it was in part of the first CARES Act. But then we didn't know how to bill it. And we kept getting incremental guidance on how to bill these things. And we finally got SE 2000, SE 20016. And that was published and revised a couple of different times, still has been. But the initial guidance that we got that allowed us to bill as distant sites in rural health clinics FQHC was in SE 20016. And it announced our distant site capability. It announced the creation of G2025, which, much like our virtual check-in, our virtual communication service, G0071 code, G2025 is a RHC FQHC specific code. Nobody else uses it. We're in SC 20016, it announced that we'll be paid the $92.03 weighted average telehealth payment. So again, much like the virtual communication service, what the payment for G2025 is, $92.03, represents the weighted average of all of the services on the CMS list of approved telehealth services. So RHCs, we can provide anything on the approved list of telehealth services. $92.03 is a weighted average of those, and as such, the RVU, I think, there is an RVU out there for that, and we're going to address that in the question section. Any healthcare provider via telehealth, this is very confusing, any telehealth, any licensed healthcare practitioner in the RHC or FQHC can practice in their scope of service, render via telehealth. So this means really we can render some low-level nursing visits. RN, not sure the licensure off the top of my head in Oregon, for example, do you have a medical assistant certification? LPNs, of course, would count. Any licensed practitioner can provide telehealth services during the PHE. This only applies to telehealth services, so that's not face-to-face. Like I said, we've got a $92.03 payment, which is the weighted average for all of the 211 approved telehealth services. We must get patient consent for the patient to know, yes, we're going to treat you via telehealth, but we must get the patient consent and let them know that we're doing that. And if you're doing that via FaceTime, let them know that they're not necessarily on an approved or a HIPAA compliant platform, and do they consent to receive treatment on that platform. So don't forget consent. We are G2025. I've rearranged my slides a little bit for this presentation, so pardon if I'm halting a little bit. We've got to use G2025 to report our telehealth codes. We've already talked about that. It's only eligible right now during the course of the public health emergency right now. Part of the rolling interpretation we had to get is what to do with telephone-only visits. So right now, and this is a big issue during the public health emergency, normally Medicare does not allow telephone-only visits. And under normal circumstances, those would be a virtual communication service, virtual communication service. Remember, part of the initial guidance was, well, you just have to bill your telephone-only visits as virtual communication. And our initial guidance was to bill them as such. But then when SE 20016 came out, we also got the ability to perform E&M services, in effect, via the telephone. Oregon says the same thing. We can provide telemedicine services via phone only, where where visual audio asynchronous communication is not possible. So we can go back and correct claims from prior to March 1 that were paid at the lower rate and bill those as G2025 if they were in fact phone only E&M visits. So we can do phone only. Phone only will be one of the things that will go away from our telehealth visits after the public health emergency. It doesn't matter what else happens. Medicare, under normal circumstances, will not do a phone-only visit for an E&M service. So expect the phone only to go away. Telehealth services, we hope not, but phone only decidedly will. It's got to be 5 minutes of service, and it's the same definition as our virtual communication service. We can't have an encounter 7 days prior, and it can't lead to an encounter within the next 24 hours. Then it would just be an encounter. Telephone only visits has to be at least 5 minutes of service by one of our approved RHC providers. We can do annual wellness visits via telehealth. We got a special exemption for that, but for the duration of the public health emergency, yes, we can do annual wellness visits on telehealth or telephone only. And yes, we can have patients self-report their vitals if they can. Annual wellness, telehealth, annual wellness, telephone only, work during the public health emergency. On any of these services, there is a coinsurance and deductible that would apply. So don't forget about that. And I think it's also grounds for confusion. We have a CS modifier, which indicates any services, including telehealth, for which coinsurance and deductible are waived. So first, CS modifier represents waiver of coinsurance and deductible. At first, we got this just to waive coinsurance and deductible for COVID-related services. In July, SE 20016 was expanded and revised to include the CS modifier being applicable to Medicare preventive services performed via telehealth. So now the CS modifier is really used, CS modifier is really used to waive coinsurance for telehealth services for either COVID-related services or preventive services. We may waive coinsurance for all telehealth services. Providers may waive coinsurance for all telehealth services. OIG will not enforce any kickback statutes that prevent us from systematically waiving coinsurance and deductible, but we must waive coinsurance and deductible amounts for anything that is COVID related. So we must waive COVID related. We may waive all coinsurance during the public health emergency. Those is a really important distinction. Also, that CS modifier. CS modifier is now revised to mean anything that we're waiving patient coinsurance and deductible, either COVID related or preventive service over the phone. There's it news one more time just to back it up. COVID related or cost sharing waive for telehealth services. The CS modifier, we may have incorrectly had claims pay prior to July 1, even if they were COVID related, even if we had the CS modifier amended to the claim, but we shouldn't collect those balances from patients, and our max should come back and adjust those claims so that coinsurance was removed where it was erroneously applied back in the early stages of the telehealth crisis, of the public health crisis. Telehealth cost reporting, we're going to report costs for distant site services. We're going to report both originating distant site costs but essentially the cost report is going to take these and reclassify them out to cost other than RHC services. So right now our telehealth visits are not included as encounters. They are not included in our encounter denominator. Do not include telehealth visits in your denominator, and we do not include the costs in to go support our rate because we're paid differently for those services. So G2025, I'm not going to talk about before July 1 because it's very confusing. But right now, after July 1, we're not going to use the CG modifier for G2025. We're going to pay at $92.03, and I meant to put the 95 modifier on here. 95 modifier is optional. We recommend reporting the 95 modifier. Don't have to report it to get the claim paid. MACs are erroneously subtracting coinsurance from the Medicare payment, which is reducing the payment down to $56. So that's one way they're paying this wrong. We don't expect that to change in the immediate future, but we need to push on that. Revenue code 52X need to be used based on what the patient location is, where they would have otherwise been seen. And 0780 is only for originating site services. We'll report 0900 revenue codes where we provide behavioral health services via telehealth. So use your accurate revenue codes. Don't use 0780. That's for originating site only. MACs are not paying these correctly. I don't see that changing on anytime soon, unfortunately. But report revenue codes. Use 95. I don't have it on here as optional. We'll want to report that because here's some of the problems we have with G2025. First of all, on the face of it, as this guidance came out, we didn't have any ability to report what services we're rendering for our Medicare patients. So coordination of benefits file would never capture the annual wellness visits versus E&Ms, what coinsurance was met, what deductibles were met, if a preventive visit was being rendered. So a lot of problems with just using G2025. If a lot of us are involved in ACOs, especially on the FQHC or provider-based cousins, how are they going to know what services we're actually rendering? How about if we have providers that have RVU-based compensation? We really need to capture their RVUs. This is a suggested method. We're a biller. North American, we're a billing company. Consider us a billing company. We do a lot of rural health clinic work, even though rural health clinic work is a big part of what we do. So I come at this from a billing perspective. We always want to capture detail where we can. So our recommendation is post the actual detail. Don't post the asterisks in there. The asterisks are to remind us that when we go to cost report and we use this claim reporting method, we have to pull these line items out of both of our claims. We're going to post the service detail line item, but we're going to suppress the detail and not report it on our claim. We will most certainly pull that detail off of the cost report. That's why we think we should use the 95 modifier so that we can report those services much more easily and pull those out. If we don't pull those out of the denominator on our cost report, we'll super erode our rate. We don't want to erode our rate, but we want to be able to capture the detail for reporting purposes. And also then, if you're doing the 95 modifier, all you have to do is, of course, pull whatever E&M services you've reported with the 95 modifier. You've got an easy reporting mechanism there. Medicare Advantage. Remember, Medicare Advantage is commercial for our purposes. We're not going to get paid a RAP or reconciliation or anything else. It's up to the Medicare Advantage plan. I will say that most Medicare Advantage plans, if they're paying you your rate, they're probably going to follow the Medicare reimbursement guidelines we just went over. If they're not paying you rate, they're just paying you fee schedule, they'll probably just pay you how a fee for service Medicare provider would be paid on these. So the Medicare Advantage plans, remember, it's commercial Medicare. For cost reporting purposes, these are commercial visits, and they're not going to be a wraparound that will go to our Medicare Advantage plans for. So when I consider using that suppressed claim detail, and for tracking purposes only, we would never put those on a claim, but then we would use that 95 modifier and again, exclude those from cost report. Patty Harper and InquaSeek and we work very closely to one another. We're going to be excited to announce some closer working arrangements between us, but Patty and I confer with one another all the time. We're both on an RHC board together, and Patty and I did a presentation about how to document telehealth visits back at the beginning of this. And basically, you want to document your telehealth visits just like you would otherwise document any other face-to-face visit. We put this together. We imported this into our own EHR We actually came up with an electronic version of that, so we don't have to scan anything. But basically, we just have a pretty standard note here that we're going to document for our telephone or our telehealth notes. We're going to just document things like we otherwise would any other note. So, or any other service, excuse me. So then where do virtual communication services come in? Remember, we have the same definition of the same service requirement with at least 5 minutes of communication technology-based remote evaluation services furnished by an RHC practitioner. We can't have had an encounter based on this condition or question within the previous 7 days, and we can't have one in the next 24 hours. So why would we do these? Well, virtual communication services, excuse me, I jumped the gun a little bit. We're going to bill these virtual communication services with a G0071, the RHC specific code. We had this before the public health emergency, and there's a lot of confusion over what we should use. This, or can we do telephone only visits, etc. The short version is this is a weighted average, just like that G2025 payment is. It includes the remote evaluation and remote communication. It does not include remote monitoring, but it also includes portal visits. So any questions or any communication we have with the patient from the portal, which is those 9942X codes, are included as a virtual communication service. And now during the public health emergency, we've got a $24.75 payment, which had been $13.75. It increased when we got those portal visits added. So remember, why would you do these? Well, these include email communication, they include texts, they would include portal visits. So we still had a G0071 available to us. Even though we can do a full-blown telehealth visit via telephone, we still have a means to do some more technology-based communication and be paid for those $24.75. And, you know, why not? So you're probably already doing a lot of these. We have some service requirements here. We're waived for the established patient requirement. We can provide these to new patients now. It's available to all patients. Again, we can't have an E&M service within the previous 7 days or next 24 hours. 5 to 10 minutes of discussion. We do have co-insurance on these visits, and we definitely still have to get consent for them. Virtual check-in example. Again, we could bill this just like we would a G2025. So we can bill it alone or with another visit, but again, what we just said, we can't have another visit with these, so probably not going to accompany another visit, but we'll use a 0521 revenue code on these. Does not include remote monitoring. All commercial insurance payers largely have their own rules. They largely follow Medicare fee-for-service guidelines. They're probably not going to recognize your G2025, but give them a shot. Can't hurt, never know till you ask. Transitional care management can be billed for telehealth. Here's a claim example if it were face-to-face, but you could bill transitional care management via telehealth. That is included on the Medicare approved telehealth services list. And remember, where are we going to find that? It's the same list as the rest of the fee-for-service world uses. It's just we've got a weighted average for it. So what transitional care management claim, we're going to bill G2025 if it goes via telehealth. Don't forget about care management services. We want to be sure, I'm not going to go through all the service requirements, but care management is still out here. Care management is another weighted average for the fee schedule payments that other providers get. The 2020 payment is $60.77 for care management services. Certainly co-insurance applies. But remember, this is telephone activity included. So if we don't have a service that meets our other service definitions, we really need to be considering getting these patients on a care management routine. You can outsource your care management. I'm an outsourcer, right? I'm not a big fan of outsourcing our care management services because it really takes all the revenue out of it. And I think we're already doing a lot of these things. We're just not documenting them well. We have to have a care plan, and our patient's requirement is that they have to have 2 or more chronic conditions expected to last 12 or more months, place them at significant risk of decline, decompensation, etc. Or remember, there's an option B, behavioral health. Any behavioral health or psychiatric condition being treated by the RHC practitioner, including substance abuse disorders, that in the clinical judgment warrant behavioral health intervention. So we've got 2 options. We've got the 2 chronic conditions expected to last 12 or more months, but we also have any behavioral health condition needing treatment. We also have this second level of psychiatric coordination of care management. Look closely at the care definitions here, because we have to have a behavioral health care team, basically. We have to have a behavioral health manager that can be an outside person that basically oversees our behavioral health program. We have this elevated level of care management service available to us. This is the service requirement for these are, let's see my next slide, I don't have that. These can all be billed alone or with a visit. This is once per month. This is a psychiatric coordination of care. And this is for 70 minutes in the first month and 60 minutes of treatment in each subsequent month by a behavioral health provider. And the payment is $141.83. My bet is there are a lot of patients that need this service. So I don't know of anyone that's utilized the psychiatric coordination of care. Everyone's a little afraid of it, but don't be. It's a nice payment over and above a rural health clinic encounter rate. Coinsurance applies to it, don't forget that. But I don't think a lot of us remember that this is out there. So please don't forget about this. And again, we can bill this with or without an E&M. So here's a great example of care management. A lot of us get frustrated because our home health certifications, the initial certification is not payable for the rural health clinic, but 20 minutes per member per month. I'll bet that home health patient, those certs and research, just have to have a care plan, easily fall under a care management scenario. So let's start to think about how we can utilize some of these services for some of the areas where we traditionally don't think we get paid, and perhaps they fit. I will challenge you that they do fit under a care management service program, which I think directly addresses our mission to expand services in our rural health clinics. We've got to get a couple dense topics here. We've got to get through some commingling topics here. But Oregon has made it easy for us for what's going to happen post-COVID. The encounter, this is a final rule that came out and was finalized on 9/15 of 2020. And when I go out and I look at the Oregon policy guidance on this, an encounter is defined as face-to-face or telephone contact between a healthcare professional and eligible HP client within a 24-hour period, et cetera, et cetera. A face-to-face encounter, and so in section 4 of the rule outlines limitations for telephone contacts that qualify as encounters. For the purposes of this rule, face-to-face encounter includes synchronous two-way audio-visual link between a patient and a provider and a telephone visit. Telephone encounters are valid services. I got my spacing all messed up when I copied and pasted that, pardon me. Prenatal care, tobacco cessation are not valid telephone-only visits, but otherwise, a telephone-only visit, a telephone-only contact can take place just like a encounter, as long as the elements of service are provided as they would be face-to-face. So basically, Oregon Medicaid, this broadens it all the way to include not only telehealth, but telephone-only visits as encounters. So there you go. Post PHE, it's cooked in to both your statute and the policy. The rule changed, and now it's already published in your guidance. So you've got everything that you need there, and written directly into the guidance is now that during a state of emergency, such as an epidemic outbreak, telephonic evaluation and management services are appropriate to ensure access to care. So you're ahead of the curve in Oregon, and there's a nice little screenshot of the actual administrative order that created that. The federal level, there have been no changes to extend anything we've gained under the public health emergency. I know that's an oxymoron to talk about what gains we've made under the public health emergency, but there's been zero legislation. We have a lot of public relief fund language, etc., but so far, the only thing we've gotten is there's an effort in the phase 4 of the CARES Act. And what phase 4 of the CARES Act is the relief package that Congress could never agree on. So phase 4 of the CARES Act had originally, the House version I know, calls for a 5-year extension of our G2025. So basically the policymakers are after a 5-year extension of the G2025. We'd rather have all-inclusive rates as for our telehealth visits. We'd rather eliminate all this G2025. I say we, that's what I'm advocating for. That's what I push for in RHC. That's what RHC wants. We want telehealth visits as encounters, not excluded from the denominator on our rate calculation, and just eliminate the G2025, eliminate the distinction, and let's get down the road. That's going to take lobbying. You're going to need to lobby your U.S. reps and senators. Let's see what happens Tuesday. It's officially October 30, so Tuesday is, of course, the election. For the purpose of folks watching this recording, a lot of it's going to depend on what happens in the election. Let's not mince terms. Some nice links if you get to the slide deck. Those are all linked to the actual articles, so don't miss those. Let's talk about commingling. It means combining funds with other funds that you shouldn't. It's a short version. So for our purposes, it means commingling Part A funds with our Part B funds and using our costs to establish a rate, billing our encounter rate, and then billing Medicare Part B fee-for-service in addition to our encounter, which would mean we're mixing funds from those that support our rate, which shows that we should report to Medicare Part B fee-for-service. So think about when an attorney gets settlements for their clients. If the attorney were to commingle those client funds with his own, that's been a significant fiduciary breach of trust and breach of fiduciary duty. That would be, they'd lose their license over that. So for us, commingling is an equally dirty word. It's the sharing of RHC space and staff for supplies and equipment with another Part B fee-for-service practice operated by the same RHC providers and practitioners. So sharing RHC space staffing cost between a Part B and a Part A operation, between our non-rural health clinic and our rural health clinic expenses. For our non-rural health clinic services, a lot of us get frightened after we listen to this presentation that non-rural health clinic services would be commingling. They're not. Again, here comes that term. By statute, we can do that. We are able to identify and remove the cost for our non-rural health clinic services from our cost report, which enables us to be able to bill those fee-for-service, non-rural health for those services that were statutorily allowed. Remember, our RHC rate is a reflection of our costs for providing rural health clinic services. So when we use a cost to determine what our reimbursement will be for our RHC services, that's what our encounter rate represents. Our provider-based clinics do the exact same thing, but they do it as part of their hospital cost report. We have to allocate costs purely between RHC and non-RHC space. For our providers, you need to do a formal time study, because I can tell you the most important impact, other than reporting expenses correctly, of course, is that FTE. And I'll tell you, one live body is not an FTE for cost reporting purposes. For cost reporting purposes, the only FTE we report is when our provider is available to see patients. So as a side note, those FTEs have a major impact. Our non-RHC services, we can carve those out. We have to be primarily engaged in primary care services, but we can also perform services beyond the scope of our RHC benefit, such as lab and x-ray, and that's part of our participation agreement. So we allocate those costs out for our non-RHC services, and we have no problem billing those fee for service. Here are a list of our non-RHC services. I've done a couple recent billing presentations for you all, and we talked about non-RHC services in those. So you see third from the top on the left there, lab services, our technical components. Of course, our professional services at the hospital would also be considered non-RHC services. We see here RHC distant site services. We see group services. Those are not a Medicare thing. Duplicate reimbursement also includes not being able to distinguish our costs, so we don't have a good basis for reporting our costs, or selectively choosing, i.e. financial triage, higher and lower reimbursement. So it would be things like we'll peel out our venipuncture and bill at Part B fee schedule. That's commingling. We're going to pull out injections and bill them on that happened during our RHC hours. That would be commingling. If we say, oh, that's a non-RHC space, let's go over there and do this, we get paid better over there. Or unbundling and billing RHC professional services as fee for service. If you have a treatment space, we can't have a little island of a non-RHC space adjacent to our RHC. We can't do that and bill it non-rural health. Everything in our rural health during rural health clinic hours has to be billed rural health. We can't have a little non-rural health clinic treatment space anymore. We can't have an island of non-RHC space. We used to be able to back in the 90s, but the Medicare Benefit Policy Manual has been written in order to preclude that and exclude our ability to be able to have a treatment space in our RHC space that we're billing fee for service. Everything during rural health clinic hours is billed rural health. We can't peel out professional services and bill them non-rural health during rural health clinic hours. Remember, our definitions include physician services, anything incident to, nurse practitioner services, anything incident to, our preventive services. We can't just, during rural health clinic hours, peel those out and bill them non-rural health. We could establish non-rural health clinic hours. We could do that. We would, let's say we want to peel Thursdays out, and we maybe think we're doing a lot of procedures, so we want to carve Thursdays out, or we have a legit, hey, we've got oncology coming through, and on Thursdays, it's oncology day. The issue is on non-RHC days, you got to post those. We're going to carve them out of the cost report. So we're carve Thursday out. Nothing during non-rural health clinic hours can be billed rural health. So it's all or nothing. You can't have part non-rural health, part rural health. Is the whole RHC is non-rural health during these hours. Posted in the manual. I would notify your state agency. I would think real hard before you establish non-rural health clinic hours. And ask yourself why, and is it really worth it? Most of the time, not getting too far down in the weeds on it, most of the time you're better off just billing as a rural health clinic during these hours and going about your business. Most of the time, as opposed to doing non-rural health clinic hours. A occupational health agreement or a payer health contract is not commingling. Do those during rural health clinic hours. Think about it. Those meet the definition of rural health clinic service. So even though Medicare patients, and a lot of the time these are cash only, this does not represent commingling. We don't have any trouble doing those. I know we're running out of time. We've got a couple space usage examples. On this example, the center of this building is rural health. And we had access pre-rural health to, on the east side of that building that weight loss clinic. So patients would check in the rural health clinic waiting room, and they would head north and east according to that building diagram to get to the weight loss clinic. The weight loss clinic had their own entry, so we were able to just put a door in there just east of that west of that file room, and sequester that non-RHC space. They had their own check-in, so they never traverse a rural health clinic space. So a rural health clinic space really needs to act like its own space. We can share a waiting room, we can share receptionists, we can share all these things, but we have to remember at the beginning of that, we have to be able to identify the costs. Part of the definition of commingling is where we could not adequately identify the costs. So be able to identify the costs, keep good records. We can share waiting room and RHC space, but we've got to be able to identify the costs. Bill your specialist as part of your RHC. You have specialists come in. You're most often easiest just have them bill the counters and go about it. If it's not going to work, sometimes that doesn't work. We have outside providers coming in. Be especially cautious in a provider-based rural health clinic, because you're going to violate your provider-based agreement if those specialists are coming in. You lease them space, that's fine. We're going to carve out their lease out of our cost report. They're going to do their own billing. Their Thursday morning, we carve out of our cost report, but the extra step we need to take is to put some signage up to say, these are not RHC providers. These are visiting folks we've got coming in, because that's where we get into some provider-based signage problems and rural health clinic compliance problems. Outside specialists come in, lease the space, carve it out of the rural health clinic, put up some signs that says, hey, these are out-of-town specialists coming in to enhance what we offer you. Then you'll be fine. If you have separate RHC and clinic specialty space, hey, we don't want to do it that way. We want a specialty clinic. They need to look like two different clinics. Share a waiting room or receptionist, but in the clinic space, they look like totally different clinics. Here's a good example of it. Specialty clinic in yellow. Behavioral health clinic in red. Rural health clinic in green. They share the north central waiting area space up there in white, but the patients are walked all the way around to the red behavioral health area when they check in. So even though these entities were all owned by the same organization, they look and feel like different clinics. Their signage indicates different clinics. They look, they feel like different clinics. It's the only way to do it if you want to bill your specialty during your rural health clinic hours. Don't forget about your cost allocation methods. That is the most important tool you're going to have to combat any allegations of commingling. Keep track of your costs and keep it tight. And a number of references here. These are our telehealth references, so please make use of these. These are our all things rural health clinic reference. You know, especially when we get into areas like chiropractic and podiatry and optometry, etc., you'll find those in Chapter 15, how Medicare covers those. But these are documents I am always, especially Chapter 13, always constantly referring to. And you'll find all of the telehealth, all of the commingling language I use. That Section 100 for commingling is directly out of Chapter 13, Medicare Benefit Policy. If you get this slide deck, follow those links. They're really helpful for care management and virtual communication. And I've probably exceeded my time a little bit, but I know we have some time for questions. So we covered a lot of territory. I know, Ron Deanne, we're going to have some time for questions during the public viewing of this session, but I don't know if perhaps some other questions have been submitted you may want to cover.
Thank you, Charles. It's a pleasure to have you present for the Oregon RHCs. Yes, we will now go to the live question and answer session. I have some questions for you, and I'm hoping that some of the RHCs will submit questions in the Q&A box. Thank you. Hello, everyone, and welcome to the Q&A portion of this session. Please use the Q&A box to add your questions for the presenter. Let's start with our first question. Charles, is there an RVU for Telehealth G2025? Charles, you're on mute.
Thank you. Yes and no. Optum has released an RVU of 1.44, RVU of 1.44 for G2025. That is not an official CMS work RVU, so CMS has not priced the G2025 yet. So formally within CMS, there is not a work RVU, but if you want a figure to use, 1.44 is your answer.
Okay, thank you. Can our RHC contract for occupational health?
Yes, or just provide, so yes, the answer is yes, and just provide it as part of your rural health clinic. You don't need separate staff. Integrate that in your rural health clinic. That is an expansion of healthcare services and fits right with our definition of what we do as rural health clinic. So I'm a big advocate for occupational health in our rural health clinics. Yes, ma'am.
Medicare isn't paying our code G2025 correctly. What should we do?
There's not a lot we can do, unfortunately. The understanding was that G2025 would be paid and we would end up with $92.03. The way many of the MACs are paying this, they're subtracting the coinsurance from the Medicare payment, which on the face of it sounds correct, but we end up with about 56 bucks, I think is what happens. Medicare has said, CMS has said, now it's upon review, that's working as intended. So right now there's not a great fix for that. So remember that, talk to your legislator slide, talk to your legislators about that. That's how we'll get action on something like that. But right now CMS is not going to fix it.
Okay, and then you answered the question that Amber Reedy had. Can you please give an example of a preventative visit that would qualify for the use of a CS modifier? And that was an annual wellness visit. Can you think of any others or?
Sure, so yeah, any of the preventive visits, I think, I'm thinking of a different state, excuse me. So yes, any preventive visit that happens during a telehealth visit would use the CS modifier. So subsequent annual wellness visits, those are probably the main ones we would use that for. For some of those others, you'd have to have hands on the patient, right? So,
right. Okay, well, that wraps up this session. That's the end of the questions that I have. Thank you, Charles. You always come with a wealth of knowledge, and we appreciate it. We will take a short break and return at 12:30 to listen to Nathan Baugh give us a federal RHC policy update and what to expect after the election. Thank you, Charles, and thank you everyone for attending this session.